Hi, this is Elliot Fishman, and welcome to Facebook Live. It's Thursday morning. I think I'm having a bad hair day. I don't know. My hair just kind of doesn't look right. It's really hard to adjust on the monitor because, you're not sure which way your hand is going. So, kind of make it worse rather than better. But anyway, so welcome everybody, and great being here. And it's been a long week, but a very good week. I guess. My son got married this past Sunday, and so that was terrific in New York. And so that's great. And now we're back to reality. So I'm here talking to you about small liver lesions. And it's a great topic, I think, and it's something that all of us face every day. As scanners get better, and this is over the years, we recognize that we pick up smaller and smaller lesions. When you pick up smaller and smaller lesions, it's probably no great surprise that many of the lesions are going to be benign, right? And so that's true both in the kidney as well as the liver as well as the spleen. So in that sense, there's no terrific surprise. The question, of course, then is, and let's be now specific as to the liver, how do you know what is benign if the lesions are very small? So it's kind of interesting. If you have a 2-centimeter lesion, you have a lot of good findings about the lesion. You could look at peripheral wall enhancement or lack of enhancement. You could look at density. You could look at adjacent perfusion changes. You could look at many things that will help you determine whether a lesion is malignant or benign. We also know, and I've given talks on CTisus, and many of you know, that lesions have signatures, and we're always focusing on the fact, whether it's kidney, spleen, whatever organ, lesions tend to have signatures. And the way you teach AI and the way you teach yourself, or you teach residents, or you teach fellows, is really by looking at signatures, that things have specific signatures. So, for example, a lesion with peripheral puddling, which then fills in over time from peripheral to central with a central scar, is a hemangioma. A lesion with a large central scar, homogeneous, bright, equivalent to the IVC, which then becomes nearly isodense quickly, sounds like FNH to me, okay? A big, ugly tumor with neovascularity, hepatoma, okay? So we do have signatures, but the challenge is as lesions get smaller and smaller, it's hard to get a signature. It's hard even to get a density measurement because the lesions we're saying, let's say under 1 cm, approaching 5 or 3 millimeters, are small. You see them because we have good contrast enhancement, they stand out, but what are they? And we do know that for the most part, they're cysts, small hemangiomas, and biliary hamartomas. Okay, that's a significant proportion of the lesions. And again, when you find them as an incidental finding in a trauma patient, in a patient with vague abdominal pain, whatever the cause might be, it's easy just to say it's just some simple cysts, or too small to classify further, perhaps. But the question then comes in, what do you do if the patient has a malignancy? Now, it's easy in routine patients or younger patients to blow small liver lesions off. But what if the patient, I'll give you just a scenario, 65 and you have a new colon cancer, or at 65 and you just diagnosed pancreatic cancer? Well, with pancreatic cancer, resectability determined by vessels, and now we're giving chemotherapy preoperatively, but the question becomes, if you have liver mets, the patient is typically not going to be resectable. Now, if you see a small lesion, does that mean the patient has liver mets? You can't classify it further. What do you need to do? Should you assume it's benign, or should you assume it's malignant? Obviously, that decision, benign versus malignant, is going to change the patient's staging, change management, and potentially change outcomes, because you do tend to make the decision that you really can't cure the patient because they have metastatic disease. So what is it you can do? Now, of course, what you can do is get another image. Well, before that, you can do is you can just wait, right? So if you said the scenario of pancreas, there's a thing there that's too small or you don't know what it is. Well, you could say, well, we're giving chemotherapy anyway. Let's follow the lesion. If it doesn't change, then it's probably just benign. If it gets smaller, then it's probably malignant. Well, if you have time and it's not going to affect the management, perhaps that's not an unreasonable strategy. But what is it that you could do if you need to know? Is it colon cancer? Is it a lesion? Well, if you were going in on the patient, like resecting a colon cancer, you could sample the lesion, and you see many times the surgeons will palpate something, they'll sample something we see, and it ends up being hamartoma, biliary, some small biliary cyst. So it's really nothing. But what is it you can do? And I think there you need some sort of strategy. And I'm holding here is a white paper from the ACR, Management of Incidental Liver Lesions on CT, a white paper on incidental findings. And Richard Gore was the first author. This was the second set of ACR guidelines. The first one was 2010. And what they did was a very logical approach in this article where there's a flow chart. Now, this flow chart, I always hate boxes, as you know, but this flow chart is about 1/3 to 1/4 the size of the old flow chart. Not that we made smaller font, but there's less boxes. And this had a very good approach to things. And it's something I guess we can think about, and you can think about in terms of practice. So what they said is, okay, what if you have an incidental liver mass on CT? And they then put it into the categories of under 1 cm, 1 to 1.5, or over 1.5. And then what they typically did is low risk versus high risk. So if they said if you're under 1 cm, which is hard to judge a lot, if it's a low risk patient, assume it's benign and nothing else is necessary. And that's probably a very, very good strategy. Now, if they said it's a high risk patient, let's say someone with colon cancer, then what you can potentially do is get an MR follow-up in 3 to 6 months. You can see what we're not saying is go today and get an MR scan. So follow it up, because typically what happens again, when something is indeterminate on one study, it often is indeterminate on a second study, and very small lesions, regardless of CT or MR or PET, it's going to be somewhat difficult to call something positive. We then said, what about the 1 to 1.5? Now, if it's benign features, leave alone. So if it has the classic hemangioma features, leave alone. If it's suspicious, then do an MRI now. And if it's not suspicious, just simply follow it. And then over 1.5, again, benign imaging features, peripheral puddling, the usual things for hemangioma, leave it alone. If it doesn't, then for a low-risk patient, you can consider MR. And for a high-risk patient, you consider MR biopsy. Now, the idea about doing a biopsy sometimes is good, but again, in very small lesions, what do you do if you have a negative biopsy? I think the clinicians often have a really hard time trusting the biopsy. And so again, it's this whole management issue. And I think it's very important to really think about radiology, not in a vacuum of us reading studies, but us being able to look at studies in the idea that we're part of the management team. I think one of the things AI might be able to do is, will classify lesions better perhaps, but also figure out in terms of management how important it is to do additional studies or biopsy, and figure out what the exact strategies are optimized for the individual patient. So let me just look, I'm looking at my scorecard here. Hey, Lydiana's on board. So Lydiana, 6:47. So Lydiana's up early, or regular time on the West Coast. So we'll say hi to Lydiana. Lydiana, I need to send you some pictures from the wedding and everything. It's just been a hectic week, and everything went well. The wedding went fine. It rained on Sunday, but it was indoors, so it was great, and everyone had a great time. And say hi to Robin from, I also say hi to Robin from Body CT. It's also a good time if you have any specific questions related to this lecture. It's probably a good time to do them. Now, one of the other things I've commented on before in terms of small lesions, one of the nice things with dual phase CT is that I've noticed on small lesions, but even though the patient's lesion may not be a vascular lesion, with malignancy, you do see perfusion changes in arterial phase imaging. You see these perfusion changes adjacent to the lesion, even some of the small lesions. I commonly see this with pancreatic cancer. On the flip side, if you don't see any perfusion changes, then it's likely going to be benign, particularly if it has other benign features. So that works very, very nicely. So that is one good thing to look at. In this article, again, I'll just make some of the points. I think it's worthwhile reading. If you go, you can download it for free. It's It's in the JACR, but it's American College of Radiology, and it's JACR 2017. It talks about things like lesion size, attenuation, homogeneity, enhancement pattern, margins, multiplicity, growth pattern, location. And we know that location, right lobe of liver, is classic for something like a hemangioma. But we also know right lobe of liver is also a great place for abscesses. So history becomes very important. We talk about indeterminate lesions in oncology patients. Although we often see a new lesion and say it's recurrence, that's probably the right thing to assume. Also, you should be able to think about the fact that we see abscesses. And patients, not so much post-op day 1, day 2, week 1, week 2, but a month later, you see a lesion, low density, maybe a rim of enhancement. You got to be thinking about an abscess. We see many hepatic abscesses that are later than the 30 days, particularly true in patients with hepatobiliary tumors, especially pancreatic cancer. And sometimes we've seen cases where it looks like it's a recurrence. You say, oh my goodness gracious, this patient has a recurrence so soon, but then you realize it's not a recurrence, it's simply an abscess. And so abscesses can develop 4 to 6 or 8 weeks post-op, where you may not think about it. So that's something to understand as well. Now, I do also like, and I'll stick with this article because I helped write it and summarizes things. They had 5 basic principles of the algorithm. And this may be good to think about. In low-risk patients, an incidental hepatic lesion under 1 cm does not require further workup. Do not look at every scan you read and advise clinical correlation. The clinicians go crazy. People go nuts when you say, lesion too small to classify, advise clinical correlation. Then the clinician says, what the heck am I classifying? What am I comparing to? Do I need to do something or do I need to do nothing? Is it something to worry about or not? And remember, it's very important now with patients reading their charts. If you're kind of a super wishy-washy for no reason, the patients will get very upset and they'll be calling you. Okay, incidental hepatic lesions over a centimeter and have distinctly benign imaging features, leave alone. Okay, leave alone. I see people with reports, hemangioma of the liver, advise MR for follow-up. Okay, if it looks like a hemangioma, it's a hemangioma. Hemangioma is the peripheral enhancement. It's different than the enhancement pattern of metastasis. It's different than hepatoma. You need to be able to understand those patterns and be able to pull a plug without ordering another study every single freaking time. Okay, incidental hepatic lesions over 1 cm have suspicious imaging features. Either do biopsy or MR, depending on how concerned you are. If it's an obvious met, just biopsy it. Whatever the MR shows is just going to show the same thing. It's not going to say it's benign. It's going to say it's something bad. The clinician's going to biopsy it. You can save money by going directly to biopsy. In this algorithm, flash-filling lesions are classified as incidental liver lesions that are characterized by uniform enhancement. In low-risk patients, they are benign, and the suggestion about 1.5 cm lesions with MR. I think if it looks like hemangioma, it's hemangioma. I've never been wrong in that regard. If a lesion is vascular but doesn't have that classic peripheral puddling, it could be a neuroendocrine tumor. It could be metastatic thyroid cancer, medullary thyroid cancer, for example. So again, it's knowing what the patient's primary is. In cirrhosis, I worry about everything because in cirrhosis, we don't see hemangiomas. If I see a lesion in the liver that's enhancing on a cirrhotic patient, it's a hepatoma until proven otherwise. You just don't see hemangiomas. Hemangiomas are vascular lesions, they're blood pool, and they collapse. Okay, if inadequate imaging is available to ascertain the presence of benign versus malignant, then they recommend an MR. And so if you have a bad CT, get an MR. So a good thing to do is do a good CT, then you don't need necessarily an MR. I think that may be a very good strategy as well. If you're looking at liver lesions, always do dual phase imaging. I know we pick up many liver lesions because we do single phase imaging, and it can be a challenge. If you're at the scanner and you're uncertain what it is, or the tech sees something, perhaps get a delayed scan. Often that extra 2 minutes will be helpful to you. On routine hepatic imaging, we do arterial and venous, which means 60 and roughly 30 and 70 to 80 seconds. We don't routinely do delayed phase imaging. Occasionally it can be helpful, but if you only had one phase and you don't have that arterial phase, it may be something that indeed is helpful. So again, I think it's a very good article. It talks about what to do. Here are some take-home points. Forgo workup of incidental liver lesions less than 1 centimeter in low-risk patients. Forgo it. Forgo workup of incidental hepatic lesions with distinctly benign features regardless of risk factors. A hemangioma is a hemangioma. Pursue workup of incidental hepatic lesions that are over 1 centimeter and without distinctly benign features in high-risk patients. So in the right population, and you're not certain what it is, you need to go further. I think that's not the issue. So really, hopefully I've told you, you're going to see many lesions today. Leave them alone. They're benign. Don't worry about it. Don't lose sleep. Don't order another study. You will only increase medical costs and drive the referring clinicians and the patients crazy, and it's not good medical care. So let me see. Carl Tussin, greeting from neurology waiting room. I hope everything's all right. Carl, if any problems, give me a call. And Imad makes the point about trauma imaging. And maybe next week we'll talk about trauma. So I'll tell Lily to put me down for trauma next week, CTF trauma. So with that, any questions? Just give us a call, Lydiana. I'll be in touch. And Robin, I'm coming across the street. And to the rest of you, it's early in the morning. Have a great day, and we'll see you next time. Bye-bye.